Get pregnant first. Nothing like sperm humor. It really isn't. Okay, so viability of gametes. You ovulate. That egg is good for a day or so. Sperm, a couple of days. But what's interesting is how you can, the coitus before or after ovulation, 72 hours before, 24 hours after. So it takes a while. It's a journey, the sperm journey. It takes a little while to get into the vicinity of the egg. And so that's why that viability is interesting. So that whole, ovulation and the temperature and all that, there's a little, it's got a little play in it. I'll just put it that way. Is that the way to put it? I don't know. But anyway. So, look at her. While they're storming the tower, 250 million sperm per ejaculate. And then one egg a month. I mean, this just describes so much about the differences. We're not the same. And people aren't the same as each other. So here's one example. So think about, why do you need so dang many sperm? Well, here's why. Because love is a battlefield. So, millions aren't retained by the vagina. That millions die in the acidic environment of the vagina. It's a hostile environment to sperm. Millions don't make it through the cervical canal. You have to get all the way north to the cervical canal and then through the cervical canal. Well, that's where that cervical mucus makes a difference. If it's thinned and ready at the time of ovulation, then that will help the access. Uterine contractions then can occur, and they will move sperm away from their upward course. And then there are uterine macrophages, which will engulf sperm as though they were the enemy. There are uterine, there are anti-sperm antibodies, and that can certainly be a thing with a couple in terms of infertility. Then, let's say you make it through, you stay in the vagina, you make it through the vagina, you get through the cervix, you go all the way north through the uterus, and then half of them go to the wrong tube. Half. Your numbers are reducing. We're losing troops all along the way. And they think they can navigate so well. I don't think half of them can't. Half of them get lucky and go to the right uterine tube. And if there's an egg there, so then you finally are to the point where you're just down to hundreds, and this is why you need so many millions. They draft, like the Tour de France. They draft. Do you ever watch the tour? Any parts of the tour? It's just, cyclists are fascinating. So, the sperm. Yes, it's OB, but we have to get pregnant, so let's talk about sperm. I love these pictures. I love the sperms on the eggs. So, remember there was the acrosome, and then the nucleus, and then the little jet-powered mitochondria that are running the flagellum. So that acrosome has, there's a high level of cell membrane with a high level of cholesterol in it, which really helps stabilize that membrane. And so that's why those proteases don't spill out. That would be a bad thing to have happen anywhere. But you really want it to happen in the vicinity of the ovum, because those proteases in the acrosome are going to help break down those cell barriers, that zona pellucida and the corona radiata on the outside of the ovum. So all those layers that are protecting the ovum. So those proteases help. So it takes that journey and knocking into each other to help break down that little acrosome head. And so that is that capacitation that takes a few hours. So that's one thing that has to happen along that journey. along the female reproductive path. And then look at them in the see that nice big egg that's going to start everything. So the release of the acrosomal enzymes that happen in the vicinity of the egg, hyaluronidase, acrosin, other proteases, basically that will break down those cells. Hundreds of acrosomal reactions are required. So the acrosome of one sperm, if one sperm got there, that wouldn't be enough to really break down those layers. So you need all those guys there storming that egg and breaking down those outer layers so that one sperm can get in. And so there's one of the sperms going through. That's a beautiful picture. I mean, come on, I don't care who you are. It's just fascinating. So then the sperm binds to the oocyte membrane, and so why is only one sperm getting in there? It wouldn't work if you had more than one sperm nucleus inside that egg, so we have to block so that there isn't polyspermy but monospermy. And so there are a couple of blocks to that. One is so the sperm reaching that ovum cell membrane causes an influx of ions. The sodium influx will just depolarize the membrane, and it helps prevent other cells, other sperms from being able to penetrate. The other thing, this is just adorable. So that calcium influx causes cortical enzymes to exocytose, and so they will just bind water and swell. So you get this kind of jelly-like border around the entire egg, and that will just prevent sperms from getting in there. It just kind of blocks them out. It pushes them away, that gel-like layer. So that's the slow block to polyspermy. I think that's just amazing. And so look, not the whole sperm enters. It doesn't need to do that. Just the nucleus does. So all that it's contributing is going to be a single set of DNA alone. The sperm nucleus is phagocytized by the oocyte, and then that ionic influx will make meiosis continue. So that's not even happening under the influence of hormone, like during follicle development, that oocyte maturation. But it is the sperm itself, that single sperm that penetrates the egg, that stimulates the completion of meiosis. It's kind of a little love story, really. You know, she's just not ready until he's there. The right one is there. And so the meiosis completes, and then the two sets of chromosomes can meet after all that. I mean, it seems like it should never happen, and yet it did. Look, all these times it did. It just keeps happening, and it really is a miraculous thing every time. So those membranes of the nuclei rupture, the chromosomes unite, and then fertilization has taken place. Now you have a diploid cell. So that's the whole deal, is that haploid gamete plus a haploid gamete forming that first diploid cell of the diploid body. So to get to pregnancy, we're going to cover a little bit of this embryology sort of stuff. So you probably remember a lot of these stages from a biology class at some point. Pre-embryonic development, so it's not an embryo yet. Fertilized egg initially, and then these various stages. So you go from 1 cell to 2 cell, and we call that the 2 cell stage. And then 2 goes to 4 by mitosis, and that's the 4 cell stage, and the 8 cell stage, and the 16, and then at a certain point we call it morula, which is a solid ball of cells. Just cells. And if you think about, it's just another one of those things, you know, when you give yourself a minute to think about it. I know you don't have any of those minutes, but just one fertilized egg and just a set of cells has so much potential to become a human. And I don't want to make you feel emotional towards a morula. I don't. But there is a polarity that thing has to be in, and when you studied embryology, there's a polarity. So how do cells even know where to go? And this is going to become everything. It's not going to just become a human. It's going to, or whatever it's going to become, it becomes also its own membranes as well. And so those, you have to really have a lot of organization. So there's a lot of genes that come on during that time that should never be on again. When they come on again, then that's cancerous. You know, those are cells that they lost their way and have regressed back to this embryonic development and are doing something different than the surrounding cells. So it's just a cascade of events that truly is, it's what we love about, it's what you forgot you love about biology. You know, is just that we're about just the cell, and you started there. And so a marula, or this isn't a zygote yet, because you have to get to all those membranes. And so I think there's tons of political and tons of moral talk about this, but biologically, that's a bunch of cells right there that some of it's membrane too. And so how you feel about that is really is just a whole other thing. Always remember, you care about your patients. That's what you care about. That's not your patient yet, you know. And so that's just, I'll just say that. The next thing that you go to then is a blastocyst, which is going to be a hollow ball of cells. Now we're beginning to migrate and move cells around to get to where we need to go. And I just have such a place in my heart for the blastocyst. If you looked at any blastocyst from, and you probably did at some point, you looked at a starfish, or you were looking at chicken, or whatever, it all looks like this. So however special we are, I don't know, but it's humbling to realize that anything that's going to end up being a mammal it looks like this. You couldn't pick one out from another one. So it's just interesting. And so a blastocele is, I say blastocyst, it's really it's blastocyst, blastocyte or blastocyst. So there is this ball of cells, and it is fluid filled. And you begin to see a little lump. You see all that exterior sphere, and then the little lump that's going to become the embryonic disc. So it's just a disc of cells. It's a mass of cells. You still see the zona pellucida there. And so you begin to form all this stuff. The blastocele is that internal space. The trophoblasts are the single outer layer, and they're going to be what eventually forms the placenta and membranes that will need to be there. So the placenta is it's the union of maternal and fetal cells. It's a capillary bed formed by both entities. And it's so lovely that you're able to have this thing be fed by maternal blood without ever being directly in contact with maternal blood. There will be a capillary bed between, and that's the placenta, formed by both bodies. And so you have to be able to have all those parts, and it comes from the fertilized egg. About day 6. A lot has already happened. So you see that inner cell mass. Trophoblasts bind to the endometrial cells, so implantation. So we're concerned really with the patient, that's the woman. And so this it's on its own. That's what's so unique about it. It's on its own and sort of will remain on its own. So the egg got ovulated. If it encountered sperm and got fertilized, then it has everything it needs right there for the time until implantation, which will happen at about the first week through the second week. And implantation is the burial of that, the embedding of that blastocyst into the uterine membranes, or the uterine functionalis layer. So remember, it was made very nice and thick, very vascular, and now this thing will bury down into it, because the trophoblasts secrete digestive enzymes against that functionalis layer so that it can get all nice and buried in. Is that just the craziest thing? It's sweet, really. Actually, it's kind of aggressive. That whole thing is pretty aggressive, actually, when you think about it. So it's getting all buried in there in this nice vascular layer because that's going to be a source of nutrients in time. Meanwhile, that inner cell mass will develop into two cell layers, syncytioblasts and cytotrophoblasts. The endometrium will proliferate while that development is continuing on, and the endometrium proliferates and it all gets covered up. So implantation itself takes about a week. At the time of implantation, or during that time, it would be about the time menses would start. And so ovulation to implantation is 2 weeks. And so that would be when the menses would start. And so sometimes implantation, you will see kind of a bit of spotting. And so your patient would think, well, I thought I was going to start my period, but my breast got tender, and I thought I saw blood, but, and you go, we're going to do a test. So those syncytiotrophoblasts from that outer layer are going to secrete human chorionic gonadotropin, HCG, and that's the thing that gets tested for in urine by those the blood tests you can buy at the store. It's also, a urine test that you buy at the store. You can do a urine test at the doctor's office. They'll typically do a blood test. But there's enough of it that levels in the blood can become detectable, levels in the urine can become detectable. And what human chorionic gonadotropin, and there are certain flavors of it, so there's alpha and beta, and there are isoforms of HCG. But what happens is the corpus luteum is going on being formed, and progesterone is secreted. So when the menses would start and all that would kind of break down, how did the body ever know it was pregnant? It's because it's the embryonic membranes itself produce HCG, and it sends up a little flare to say, I'm here. And that tells the ovaries to continue, that corpus luteum to continue to make progesterone. Then that will have an anti-estrogen effect and just keep the uterus quiet. So that's really cute. It feeds back to the system to say, don't slough. Now, if there isn't enough or the timing isn't right, you see that would be a spontaneous loss of that fertilized egg, which is super common. And the body never knew it was pregnant, and that happens. And so that is within that couple of week period, which would be sort of normal to see that happen. So look at age of embryo in weeks. So you go over here to birth, and just look at the hormones there. So HCG is made, a lot is made when you test it that way. That's a big flare coming from that fertilized egg. And then you see progesterone is being made, and it increases over the pregnancy. And HCG can decrease over the pregnancy when progesterone has really locked in and started being made at high levels. And so let's look again here at 12 weeks. It's happening from the progesterone is coming from the corpus luteum until the placenta takes over its production. And then the placenta, which is a much bigger organ than the corpus luteum, is able to make a lot more. So HCG targets the corpus luteum to continue the secretion of progesterone. Also estrogen is made as well, so starting at about week 4. And so that would be about the end of 2 weeks after implantation. So the missed period has been missed for a couple of weeks, if everything was on time. And then it spikes by week 8. So the chorion will develop from the trophoblasts and take over the HCG production. So you kind of have this cascading which cells make it. It declines to pregnancy levels at about 2 weeks, 2 to 4. Detected in blood at about 3 weeks of gestation. Placentation then is the production of that placenta, forming from embryonic and maternal tissues. It's from the chorionic villi, and decidua will form the placenta. So the decidua basalis, that's that basal level layer of the uterine lining, will come from one direction, and the chorionic layer from the other from the embryo will go to that direction. And they're just going to kind of finger and meet so that you have a real spongy vascular space for blood to mix. So, I won't give that example exactly. But chorionic villi, these are projections from the chorion produced by trophoblasts, which will be on that outer layer of that developing egg. And it fills with embryonic vasculature. So you have vasculature coming from the embryo in those chorionic villi, and vasculature coming from this side so that they can meet. They don't ever meet, but it's just like a capillary bed. So instead of artery to vein exactly, it's kind of artery to artery in a sense. So two different beings instead of two different parts of the same system. Decidua basalis is forming from the endometrium, and it fills with vasculature. And that's complete at about 12 weeks. I will tell you that, so this is the thing you can't see. So when your patient is pregnant, tons of body changes are happening before anyone can see anything. And so I think it's so easy to be very deferential to someone who's big pregnant, and I think we probably should help them with the door or whatever, you know. But we certainly ask them how they feel. But it's this first 3 months where people are having a lot of effects of pregnancy, but nobody can tell. And so I think it's a great time to be gentle with her and tell her that she is climbing, her body is climbing a mountain that nobody can tell. It's you're still on that mountain during the rest of the pregnancy, but people can tell. You know what I mean? Like that she's on an island in a sense. It's an island with a mountain. Where is she? I think she's in Hawaii. That might explain how she got pregnant. It's vacay. But I just think that, you know, it's interesting because the body is building all of this tissue, but what we're really seeing later is all this embryonic tissue, and then the baby, and then also a lot of fluid is what we're seeing when we're looking at a pregnant belly. So here, building a placenta makes people tired, and all the hormones make people sleepy, and you pee, and you're tired, and you feel things with great intensity. And so I think it's a great time to tell somebody to be gentle with themselves. Treat it as though it were arthritis. Take the load off. Be nice to yourself, because she's going to want to keep proving that she's still able to re-roof after work. You're climbing a mountain, you're building a tissue. So in that first 12 weeks, you're building a placenta. And a placenta is every bit as big as a baby. You know, just nobody can tell you're building it. So it's such an exciting thing, really. So look at this umbilical cord. We know that vasculature is embryonic. And then the maternal villi, and this is here coming from the basalis layer, really. And so maternal artery, so I said there was just like this vascular space where maternal blood will kind of be spilling into here, and then all of this vasculature from the baby is just being soaked by that. And so it's able to pick up its fetal red blood cells, and its blood is able to pick up nutrients from the maternal blood supply. Nutrients meaning also oxygen. So here's the placenta, the fetal side, and the maternal side. That picture really grossed my husband out when he walked by. Of all the things, he just was like, "Oh, wife, that's gross." I'm like, really? I don't want to eat it, but I don't think it's gross. But mammals do, so I'm not putting that down. So back to the embryo. Oh look, it's so cute with its little fishy tail swimming in amniotic fluid. The extra embryonic membranes are those membranes that will surround what was once the inner cell mass, the embryo. So the only place that it's really living in a bubble, living in its own baby in a bubble. And so then you just have where the umbilical cord is kind of piercing it, full of amniotic fluid, which is maternal fluid and fetal urine. It cycles very quickly because of the placenta, but that's where it comes from. And so there's more fluid over time, turned over every 2 hours, which is good. Creates a nice quiet environment. I don't know how quiet, you certainly transmit sounds, but a stable environment thermogenically, and allows for free fetal movement. So here are the embryonic membranes. From the very outermost is the chorion there, which we know was very outermost and had villi that helped create that placenta. So that's on the outside, so forming the placenta, fusing with the amnion. The yolk sac forms from embryonic disc cells. Blood cell formation is coming from there, which is interesting. So where are blood cells made in a neonate or a toddler or you?
Marrow.
Thank you. From bone marrow. And so when you're an embryo and don't have bones, where is the organ that's making blood cells? Well, it's the yolk sac. And some mesoderm along the way as well. So that's kind of interesting, isn't it? It makes sense. So this is what is feeding, if this is something that's in an egg, this is a little zoology kind of thing. But so your egg, when you eat an egg and you have that yolk, that's really that was the food that was really feeding the growing chicken or whatever, snake or whatever, because it didn't have a connection or an outside source of nutrients like a placenta. So in this case, the yolk sac is doing something a little bit different. So that's why you have that same term. A yolk sac gets smaller as the growing embryo would get bigger if that were inside an enclosed egg. So that just works perfectly. But anyway, here you see that as being a source of blood cells, which is really interesting. And also the germ cells, which will seed the gonads. It's just kind of magical. Chorion is the outer layer. The allantois is now pocket from the yolk sac and will form the construction for the umbilical cord. And that actually becomes part of the urinary bladder too. So do you remember, did you do a fetal pig? That when you pulled back that, you dissected around that umbilical cord, and that's where the urinary bladder was. So there's something very mammalian about that creation of those organs. Okay, so that was forming, those are the extryonic membranes and the placenta. So let's go back to development of, that's kind of a hiccup there, but kind of back to the development. So you had a fertilized egg, we're trying to get pregnant, got pregnant, we're trying to, get to the point where we need obstetrics, I guess. So you had a 2-cell stage, cleavage stages up to a blastocyte or blastocyst, and then a gastrula will form. And a gastrula, so here's all your cleavage stages, and then a hollowed out ball of cells, blastocyst. And then gastrulation will be this, this tissue that will form and vaginate into that interior wall, and that's how you can really see where you get this, all the different layers beginning to form. So an inner cell mass will begin to dive into that blastocell and form 3 primary germ layers. So a 2-layered inner cell mass becomes 3-layered. And from those 3 layers, so this is cute, just recall that at the time of fertilization and during all that, those will become all of those extraembryonic membranes. The yolk sac, allantois, chorion, all of that is embryonic. So fetal material, and just some of that will become the disc. And then that will form the gastrula, and you get all of these membranes forming, or all these germline tissues, ectoderm, endoderm, mesoderm. I know you've gone through those before. But overall, the ectoderm will form the skin and nervous system. Mesoderm will become the notochord and kind of everything else, and endoderm is epithelial lining. So when in doubt, I think mesoderm is a good answer, unless it's nervous system or skin. So you have all this orientation that has to happen to make sure cell populations migrate to the right layers. And then once you're trying to develop the actual embryonic body itself from those three germline layers, you have a primitive streak that starts to happen. And so you have kind of a diving of this tissue in. So look, here is endoderm, future ectoderm, and then there are cells that will populate the interior and become mesoderm. So that's really early on while you're trying to set up 3 layers, and a primitive streak will happen, and that will establish bilateral symmetry and kind of replicate this place where the spinal column will be. Organogenesis, so how do you make all the organs? And I just want to, I think it's real pivotal to talk about the notochord specifically as one of the organs that develops. So you start out with these, so look at this inner cell mass, this gastrulation has occurred, and you ended up with these 3 layers up here. And so you have a primitive streak kind of beginning to form as you have this diving and moving of layers. And so we kind of form from the that neural tube or notochord out. And so you just see these pictures, you begin to, some of this mesoderm kind of breaks off and forms its own chunk. And it's going to be a rod-like structure of mesoderm that will replicate the positioning of the spinal cord and vertebral column. Notochord. So that's the first place. We don't really end up with notochord layer, you know that, but some animals do. And so anyway, that's one of these very mammalian first things. I don't want you to forget that we start like so many things did, and it's just, you know, and then things become human. But so look, here's this notochord forming. And above it, you see this tissue that's the neural tube. The notochord goes away, but the neural tube stays. And that becomes ultimately the start of the nervous system, the central nervous system. So the notochord is derived from mesoderm, signals neurulation, or the formation of that neural tube. Forms axial support, and it will persist as part of the discs later. So it really is cartilage and structure. Neurulation, just to continue, you see it's starting to form, notochord forms, you see where it is in this picture. I'll show you here, the neural tube, notochord, and the notochord neurulation is surrounding the notochord, forming the neural plate. Then look, neural folds come, a neural tube. First the notochord, then the neural tube. The two detach, the anterior end forms the brain, posterior portion forms the spinal cord. So the notochord forms and neurulation occurs as kind of along the length of that. Neural crest gives rise to all the various autonomic ganglia and the adrenal medulla. So think about that. It's endocrinology. What's really there first? The adrenal gland and the nervous tissue. It's cute. And so the adrenal gland was nervous tissue arising from ectoderm, by the way. So that's just really interesting. And I mention this because it's a real big deal. It's one of the first bits of organogenesis to happen. The first organ that forms is the notochord. And we don't ever talk about that because it's not there anymore. But then neurulation occurs, and it occurs super early. So by day 23. And so this is where that, early information about pregnancy becomes really important, because that body is forming the nervous system, the central nervous system for that whole being really early. The endoderm, so that was coming from ectoderm. Endoderm is going to end up being a lot of the linings of things, and so there's just a lot of folding that goes on, and the first organ that's forming from endoderm is the gut. And if you've studied embryology and mammalogy, you really follow that. That's a really big deal. Where does the mouth form and where does the anus form? And that is one of those things where you had zoological taxonomy based on that. And so that's when the first endoderm organs to form is gut, and then things can form from around that. Mesoderm, so you have the notochord there, and then somites form. That's kind of the next chunk of things that would really form. And so you have all these somites, 40 pairs of mesodermal blocks that kind of form around that notochord, and it's complete by the end of 4 weeks. So there you are with the progenitor of all the rest of the stuff. And it's 3 major things. The sclerotome forms vertebra, myotome, skeletal muscle, dermatome, skin. And that's how where you see the ectoderm is nervous tissue. Dermatome is dermis of skin. The rest of skin can be ectoderm. Endoderm is gut linings and linings of stuff, and then mesoderm is everything else. So there you go, embryonic development, kind of in a little pictorial form so that you can see the 2 things. I don't know why I said the 2 things. It's the things, the many things. And organogenesis, what comes from where? I don't really care so much about this, but along the way you'll hear, oh, it's an ectoderm derivation or this or that, so that's where that comes from. But it really, it's about the fact that we really were just layers, and it was a directional process with orientation to become something eventually. So, something that we care a lot about is fetal circulation. So the yolk sac and some mesodermal cells will form blood cells. Mesoderm spreads to form a vascular network. That's an easy sentence to write. So then the mesoderm will make the vascular network. But you've seen the vascular network. That's just, how? How does that ever happen? And turn out bilaterally. Wow. So by the end of 3 weeks, 2 vessels have fused and bent to form kind of a rudimentary heart. CVS functional by 8 weeks. Fetal circulation bypasses liver and lungs. So one of the early things that has to happen is, recall there is no, that this is being fed from a nearby source. And so you have this, once you're just an egg, you're implanted, that's fine. But you get to this point where you're suspended in a lot of membranes, and you're really detached from that uterine supply. You better get the supply of nutrients quickly, and that's going to be by a CVS forming within the embryo and hooking on into that existing placenta. And so that's all happening at the same time. The placenta is being formed, and that CVS had to be functional. That makes sense. It had to be there and be functional. Some vascular modifications. I don't know if you would have talked about these at any point, really, during cardiovascular systems, because you had some errors, congenital errors. So you have the umbilical vein, which is carrying freshly oxygenated, high nutrient-rich blood from the placenta to the embryo. You have a singular vein. A ductus venosus will send blood from that umbilical vein directly into the inferior vena cava. You don't have to process incoming nutrients from the gut at the level of the liver because they're not incoming through the gut. So you can just bypass the liver and go straight to inferior vena cava. If it's in us, you eat, nutrients go from the gut to the liver and then to the inferior vena cava. So we just bypass with the ductus venosus, foramen ovale between the intra-atrial septa, or it's in the septum between the atria. Ductus arteriosus, one of my very favorite things you can see on the fetal pig. And everybody has a favorite fetal pig structure, am I right? Ductus arteriosus was mine, and you can just see, just right between the aorta and the pulmonary artery, this fully formed vessel. And it's not like it's just a fake vessel, you know, it's only there for a little while. It's so there, it's hard to imagine that all that just closes up and goes away, but it does. And then the umbilical arteries, which will deliver blood back from the embryo back to the placenta. And there are two of those. They arise from the internal iliacs. So cute. And then here's just a picture of that to envision the circulation. This isn't, you know, you don't have to know this, really, because this isn't, you know, what we're doing. But I do like this picture, these pictures, and you just kind of see what's going on at various months. You don't even read it or look at it if you don't want to. But I think what's neat about it is, you know, look at the size of that head. But just to kind of see what's functional and how soon and all that, I think it's kind of interesting to look at that. And still, that doesn't really look like a baby. You know how big their damn heads are. If you've had one, you noticed that. God. But look, just it's interesting to kind of see what goes on during the fetal period, but I'm not going to ask you stuff about that. Is that your favorite picture you've ever seen right now?
No, that really freaks me out.
Does it?
It's really cool.
That's so cool.
Well, it looks like it's trying to get out. That's why. And that's the whole problem.
Ma'am.
Did I tell you this? This is what it feels like. Have I told you this? When it's like men, a lot of bodies won't ever feel what it feels like to be pregnant, but it's like this. That's exactly what it feels like. Because you can feel it moving around, but it's not as distinct as this. It's not like this. It's like this. Quit it. It's so weird. So, viability of fetus, not a big deal to know this or anything, but I just think it's interesting. The percent, of course, goes up the farther along the gestation goes. But look at the wide variability. So where that baby's born is a big deal. We're in a big city, so ours is pretty high. If you're in a rural area, it takes a little longer to get there, that kind of thing. But this 22, 24, you know, somewhere in there, you're hearing about 22s a lot. They make the news, 21s. But this is, you know, certainly the further along the better, obviously. I think that's a cool picture. Did you ever see the movie Alien? It's not It's so weird. Sexual differentiation. This is so cute. So this makes so much sense too. So when I was learning all this stuff many moons ago, man, we just didn't really talk about anything but male and female, you know. And there's a whole lot of births that are a little more indistinct than that. And when you don't, people don't really, you don't really hear about them, you don't talk about them. They used to just wait and pick one for them and do a surgery or whatever. And so now this ownership of it is what it is I think really important. I think what is so interesting is at the same time we're starting to really embrace the fact that people land in a lot of different places, sort of gender-wise, emotionally or physically. At the same time, we're becoming more tolerant or aware. I don't know that the word tolerant is exactly right, but there's more social understanding. At the same time, there's so many freaking gender reveal pictures, and I just think that's really. You see there's these elaborate cakes and balloons and this is and that's and the baby, somebody pulls something, you know, whatever. And then, oh, it's a girl, before it's ever born. And so I think it's just really, it's just, I've noticed an interesting juxtaposition between society loves a gender reveal because it's so and stuff ready. And then yet we're having a lot of people who don't feel like they're one or the other. You know what I mean? So where's that gonna all go? I think it would be great to go, we don't know. We don't care, we love you. You know? So I didn't find out what the gender of my baby was. I'm so glad I did it that way. It's just like, don't look at the Harry Potter books before. I mean, know your gender, it's fine, it's great, we have all that technology. But I do think we already start to have belief systems about who that being is. You know, you're projecting the minute before you even meet a guy, you're thinking, and she's gonna be named Zoe, and we're gonna dance. So we're all screwed from just the first date or beyond the first date. You know, about somebody is projecting an agenda onto us. So I think your goal as a practitioner is to be thinking about the patient, just who they are as they are. And so simmering down, because one of the reasons is this. So there is a sexually indifferent stage. So you've got a freaking neural tube formed, but the reproductive, that's pretty, I mean, we're so late with reproductive information is that we're not even at puberty. This is one of the last things we do, and that's appropriate. But at first it's just some ducts and a couple of glands, and everybody looks the same. So you see them here. I feel like maybe Dr. McNeil might have touched on some of this at some point. I'm not really sure. But what you have are just some gonadal ridges from the mesoderm, and they become seeded with gonatogonia from the yolk sac. And so those don't have to be anything but cells that are destined to undergo meiosis. They don't have to even, you know, be specific gametes yet. So you have those pregonads, or come from the gonadal ridges, and then there are two duct systems, paramesonephric and mesonephric. And so probably during pathophys, maybe of the renal system, you might have done a little bit of this. So paramesonephric was also Mullerian, and then mesonephric Wolffian. So if it is an XY embryo, or boy, male embryo at about 7 weeks, the gonads will be influenced to become testes, probably from factors on the Y chromosome. And so the testes will begin to secrete testosterone, and that will influence the ductwork to go a certain way. Seminiferous tubules will develop and merge with the Wolffian tubes to become the male anatomy. So the gonads are giving rise to the seminiferous tubules, which makes sense because that's what the testes are, and they'll fuse with the ductwork that would help conduct sperm to the outside. So utilizing those mesonephric ducts. Wolffian. Don't know why I said that. It's very masculine, Wolffian. And then the mesonephric ducts form remaining duct system. And then the other ones degenerate. Now, if you don't have a Y, you sit there for another week, and the default gender then would be development into ovaries. So that's kind of interesting. And the word default there is meaning to give no particular information. But you can see then why the duct and gonads, there can be some, maybe things don't completely get where they were supposed to go necessarily. And so you have kind of indiscriminate genitalia or so forth. So here's just an example of what happens along the way and how you really have all the analogous things from one side to the other. XY embryo at 8 weeks, there's a genital tubercle that will become the penis. The folds will enclose the urethral groove and form the urethra. Labioscrotal swellings fuse to become the scrotum. So you can see that how similar really that all is from one side to the next. So if it's XY, the genital tubercle becomes the clitoris. So that's the analogous structure. Urethral folds form the labia minora. Labioscrotal swellings form the labia majora. They don't fuse. And so when they do a surgery to take male to female, they just invert the penis to form a vagina, basically. You can kind of see how that would work. Kind of. So sexual differentiation, one of the things that has to happen is one of those sets of gonads needs to get to the exterior. And so at about 32 weeks, testes migrate to the anal canals. Gubernaculum. What am I trying to say there? This becomes part of the spermatic cord. The ovaries will descend a little bit, but not very much. It's a short distance. And that same gubernaculum, that same thing. I'm having word problems today. Splits, it's still there, but it becomes ovarian and rounds ligaments. So all the same bits, we're not that different, except for this. I love these pictures where they show the fundus of the uterus and where it should be during obstetrical exams. So when you look at that, it looks appropriate that you have weight established below the waist in preparation for that kind of distribution of weight that body would have later. It makes sense. So what happens during pregnancy? So you got pregnant, the embryogenesis and all that about what happens with the embryo over there. Now what's happening with the body while this is all going on? Increased in vascular network and engorgement of blood. So the blood volume increases a lot. Chadwick sign, a bluish hue to the vagina maybe. That's, not anything really anyone sees. Breasts enlarge, areolas darken, melasma or skin pigmentation is typical. It may stay, it may lighten, but that's sort of an interesting additional thing. The uterus occupies pelvic cavity by 16 weeks. This is why the uterus was impressive during that thing it just ends, and you have this growth. It's just amazing. Hypertrophy of myometrium, so you have growth of muscular tissue so it can stretch. Amniotic fluid increases. By 7 months, the fundus is above the umbilicus. By 9 months, the fundus is at the xiphoid process. She can't breathe. Oh, it's just so wild. So I follow a lot of photographers that take pictures of babies and pregnant women. I don't know what that says about me. But the process it's so interesting because when I was young, you did not see a pregnant belly. You did not see a pregnant belly. It was held very privately. Now, I don't know that that's good or bad, but Demi Moore appeared on the cover of, I want to say, was it Newsweek or Vogue, or not Vogue, it was some magazine, and it was shocking, and she was undressed, unclothed, and she was covering herself, and she had her pregnant belly just on the cover of the magazine, exposed. Now everybody knows what it looks like. It's just such a different time. I still wear them. But it's just so different now. They're bikinis, and people are tan when they come in to see you, and it's lovely. I think it's great that we sort of embraced that. We were very, they didn't even talk, you would even say, if somebody was pregnant on television, they couldn't even talk about it. I don't know, it's just so funny how things have changed. Anyway, now I'm so fascinated by pregnant bellies. Weight gain, 30 pounds, 80 pounds, whatever, But if it's 30, for example, just for you to see where it is, because that baby was only like 8 pounds. But look at the placenta, a pound and a half, amniotic fluid, 2 pounds. Boy, that's a lot of what you actually visibly see. Uterine enlargement itself, a couple of pounds. Maternal breast tissue, 2 pounds. Maternal blood volume, 4 pounds. Fluids in maternal tissue, just swell up, 4 pounds. Maternal fat store, 7 pounds. Just to show you an example. And so it's interesting because as much as the pregnancy is out there, so are these post-pregnant bodies, and it's just a lot. And I think you need to be that voice of reason for your patients and tell them to be gentle with themselves. That's really important. What are some of the physiological changes during pregnancy? Increased salivation. That's interesting. So you're just sitting there, hotter than hell and drooling. and then it's such a lovely time. Nausea and vomiting, really typical, especially during that first 12 months. Certainly can last longer. Constipation, hemorrhoids, urinary fetal metabolic waste, increased volumes. There's a lot of urination. Plus, if you'll remember where that uterus is sitting, it's really just sitting on top of the bladder. So a lot of increased frequency for a lot of reasons. Nasal mucosa congestion, nosebleeds, gum bleeds. Did anyone know? My gums I brush my teeth and my gums just bled every day. There's just such an engorgement of fluids. So increased vital capacity and heart rate. So you really the pregnant body really becomes quite a machine for the pregnancy. Increase in blood volume, 25–40%. Increase in blood pressure, heart rate. Decreased venous return. Varicosities. Increased cardiac output. And so these are the things that can feel uncomfortable too. So just want to encourage enough activity in some, and encourage more rest with the feet up in some. So you use as directed. So placental hormones. Did you ever know there are pregnancy hormones? Certainly placenta is making progesterone, but there are a few others. Human placental lactogen is interesting. What would you think lactogen would do? It is important for mammary tissue. Glucose sparing effect for the female. So fat reserves are quite enjoyable. You want to keep enough glucose available, the blood glucose level available for the infant. And so blood glucose is really heavily followed during obstetrics because it's certainly gestational diabetes is a big deal. But it's interesting because there really needs to be a little bit higher glucose level during that time to enable fetal tissue as well. So also there is human chorionic thyrotropin, which is similar to TSH and would stimulate the thyroid. Isn't that just phenomenal? That makes so much sense. If there was a gland you wanted to increase, it would be the thyroid gland. Help increase the metabolism and sort of this promotion of all the systems, metabolism and maintenance of all the systems. Relaxin relaxes the pubic symphysis, and I swear it makes your feet big. But you need to have a softened pubic symphysis for delivery, softened joints so that this body can expel this thing. And it really goes back. Softens and dilates the cervix. Relaxin. I can only just hear the Fresh Prince song. HCG, produced by the corpus luteum, also then by placenta, and helps induce progesterone production. Do you guys want a little breaky break? Let's do it. Take 5.